Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echovascular, general, high-risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Juliet Cullins is a board-certified health and wellness coach specializing in helping women 50 and over thrive through holistic habit and the wisdom of Ayurveda. She is also a registered diagnostic medical sonographer with years of experience bridging Western and Eastern medicine. Juliet offers practical tips for balanced circadian rhythm, building strength, eating clean, and improving sleep. Whether you're looking to reset your habits or embrace vibrant health, this conversation will inspire and empower you. Her flagship program, Body Reset, introduces 10 transformative holistic habits and supports women in sustaining them through a comprehensive one-year journey. Thank you, Julia, for joining us today on this podcast. Please help me welcome Juliet Cullins. Thank you, Juliet, for joining us today on this episode. We are going to talk about liver transplant. So this is not my zone of expertise, but I've enjoyed working and talking with Juliet, who has a broad experience in ultrasound, general, but also a specialization in liver transplants, as well as being a health and wellness coach. And so she shared in a previous podcast that we've had with her about different tips on habits. And so I encourage you to go back and listen to that, because she had some great tips to help us with just developing those habits, despite the fact that as ultrasound techs, I think we're immensely experts on developing habits in our own ultrasound practices. Juliet gave us great tips personally too. So thank you, Juliet, for joining us to talk about liver transplants today.
Thank you. Glad to be here.
Yeah, so let's just talk. You have designed an outline, and so I'd like to just talk about, first of all, what is the role of the liver, to understand this process a little better?
Yeah, so the liver is a vital organ. Most people know that, but it's in your right upper quadrant, which means in your right upper abdomen area. And the role that the liver plays is it is a filter and detoxification of blood. It produces bile for digestion. It regulates your metabolism. It supports your immune function, and it also breaks down your red blood cells. So that is the role of a liver.
And one of the largest organs in our body, right?
Yes, one of the largest organs.
Yeah, so that's a huge role.
It's really important, because also the liver keeps your blood clean by removing harmful substances, and it also helps you to digest and absorb your nutrients efficiently. And then another role it has is it stores energy and regulates some hormones in your body.
Yay, right?
Yay, hormones. Yeah, I know exactly. Energy and hormones. Yay.
Right. That's awesome. So what are the most common reasons that patients or people need transplant?
Yeah, so, well, there's a few. So, chronic liver failure, which is more of a gradual over time thing, like if you were diagnosed with cirrhosis, depending on the stage of cirrhosis, it could be 2 years, 5 years, 10 years. Like you have cirrhosis, you're trying to manage it. Some people never get to the point where they actually have to have a liver transplant, but that's considered a chronic liver failure. More something like hepatitis B or C, Also something called NASH, which is the acronym for non-alcoholic, non-alcoholic steatohepatitis, which is basically a fatty liver disease. So some people that have fatty liver disease, it can be hereditary, it could be diet, it could be both. People can reverse it. They can, be mindful about what they're eating and all that stuff. Another form of liver failure is acute liver failure, which is more of a rapid or sudden onset. So it could be caused by like taking too much Tylenol, which can kind of wreck your liver. And I've actually scanned patients who have said, yeah, my liver is not in good shape because I took too much Tylenol, which is yikes. You have to be really careful about that stuff. So toxins, or something like a severe infection could do something to your liver, which could potentially be out of your control. There's also genetic conditions that can cause it. I know there's just a couple I know of, which one is Wilson's disease and the other one is hemochromatosis. Also liver cancer, of course. When the liver isn't able to be surgically like dissected, sometimes they can take the portion of the cancerous liver out and you have a better outcome. But if it can't be surgically removed, you can also have things like biliary diseases, primary biliary cholangitis or biliary atresia, or there's one called PSC, which is primary sclerosing cholangitis. So there's about 5 things that can cause liver disease, and I'm sure there's others that are maybe not as common, but those are the common ones that can cause you to be in liver failure.
Awesome. So tell us, what's the role of coffee then in the liver?
Oh,
I thought this
yes.
was interesting.
I know. I actually, when I've scanned patients in the past and they have said, oh, yeah, my doctor told me I need to drink coffee. And it helps with liver fibrosis, and it also actually slows cirrhosis progression down. And it's also supposed to lower the risk of liver cancer and improve enzyme levels. And it's very anti-inflammatory. So keep drinking your coffee, man. How I look at it
I
is
don't think
I'm drinking
anybody needs
coffee.
a reason to keep doing that. That's for sure.
Yeah, so it's interesting. Some people, they are like, I don't like coffee, but my doctor said I have to drink 1 to 2 cups a day. And, so they have to figure out a way to do that just to, because of their liver, their doctor's recommending it. So it's
Wow,
usually, I
that's
think,
interesting.
about 2 to 4 cups a day, I think is what they mention.
Right.
And from what I read, I don't think it matters if it's caffeinated or decaffeinated. Some people are really sensitive to caffeine. So I understand that because I'm one of those people. But I think decaf works just as well, but I've read.
Wow, that's awesome.
Yeah.
So what is then the role of ultrasound in the liver transplant?
Yeah. So the ultrasound is a pretty essential imaging tool that they use in the different stages of a liver transplant. They do use it in the OR to make sure once they've connected all the vasculature within the liver. I know that the surgeons will use it usually on an open abdomen to make sure like the hepatic artery is perfusing and all the vessels are perfusing. But we also use it as a pre-transplant evaluation. So a lot of times somebody will get worked up for a liver transplant, which means they're going to get put on the list to see where they stand on that list. Are they high on the list? Are they low on the list? Where are they on the list? So one of the things that we do in the pre-transplant evaluation is totally reverse that, is to do an ultrasound, and we do liver Dopplers. Usually those liver Dopplers are not super pretty because somebody's in liver failure. So it's very difficult to get all the vessels. So we do the best we can. We can also look at the liver size. We can look to see, does it look cirrhotic, i.e. does it look nodular? We do like a liver capsule image where we show the capsule of the liver like way close up and just show what it looks like if it's super nodular. We can look to see if there's tumors in there, cysts. We can see a lot of stuff with that, and also we can look for ascites. A lot of people that are in liver failure do have to come in frequently for a procedure called a paracentesis, which is where the liver's not working correctly. So the fluid that normally gets circulated within the liver is just free in your abdomen. So we have to remove it via like a suction situation. It's a minor thing. People do it. They're awake.
Paracentesis.
Paracentesis, yep. So we evaluate if there's fluid in the cavity, and which is a common thing in end stage liver disease. We see that frequently, unfortunately. And then post-transplant, we are asked to come usually to the ICU after a patient comes out of the OR to make sure we can see all the vessels and that they're patent, that they look normal. There's not any like
No
strictures
clot.
that we can see, or something called a tardive parvis, or just anything that doesn't look normal. And usually somebody from the transplant team is usually present when we are doing the ultrasound, and we're communicating with them like, hey, this is the hepatic artery, this is the portal vein. Usually they know what they're looking at, but we try to say like, hey, this looks okay. The patient, this patient's liver looks okay. So those are some of the roles that we're asked to do, to use for the ultrasound in the role of pre-post liver transplant stuff.
So I know when I have worked in they have a liver elasticity, I think, calculation now. Is
Yep.
that part
Yep.
of your pre-evaluation?
Yes, that's a great question. So the elastography is not something we do, but we work in conjunction with a liver transplant clinic. And that clinic, and they use ultrasound. We just don't have the software on our machines. That clinic does the elastography for the patient to measure the patient's liver stiffness. And obviously stiffer livers, tend to be in a little bit worse condition. So yeah, so we don't actually do that. Those scans. Someday, who knows, we may end up, but I think the transplant offices are doing them now and then sending them to us to do the ultrasound part of the Dopplers and the rest of it.
Yeah.
Yeah.
Earlier, you also mentioned the term tardive parvis. Can you just explain to some of our our listeners who don't do transplant exactly, what does that mean? When
Yeah,
you
so
do see that.
TARDIS parvis is, and I'm going to see if I can say it correctly in the proper terminology, but it's basically where the waveform is blunted at the top. And so it can indicate there's an obstruction or a stricture or something's not flowing correctly. So it changes the way the wave looks. And it doesn't look normal, like with that upstroke, that high upstroke you get, it'll look more flattened at the top. And then I think the acceleration time is different too. I'm trying to remember, but it's mostly I think the flattening of the top of the wave.
And a slower flow pattern, right?
Yeah, it's more of a slower pattern as well. And we don't, honestly, when we scan, we don't usually make that call. We may point it out on a worksheet or when we're done, but we let our radiologist make that call because,
It can be pretty subtle. Yeah.
Yeah, it can be subtle and sometimes they'll call it, and I wouldn't have necessarily thought it was, but maybe they feel like it's a little bit like that, which is okay because then we know to follow up on it.
Right. Right.
Yeah.
So, I know the liver's a fixed structure. Like, my expertise is high risk maternal fetal medicine. And so we have several windows that sometimes we can use when we're doing Dopplers, right? Of the cord that floats around or
Yeah.
in the head or in the baby's belly, whatever. But the liver itself is pretty fixed. So you use a lot of angle correction, right?
Yeah. Well, yeah, that's a great point to bring up. So we basically, I want to say mostly like intercostal tends to be a really good way to get to the liver. It depends on the body habitus of the patient. Sometimes we're doing large patients. But it also depends. Sometimes they'll do a partial transplant, which means somebody donated a lobe of their liver. And so in the instance of, let's say somebody donated a left lobe, your window is like right here. And if you go here, there's nothing there because there's no right lobe. So it really depends on the transplant. If it's a
So
full,
you're pointing to like the xiphoid
yeah,
process
kind of, yeah,
or
mid-sternum,
the right
xiphoid.
subcostal area?
Yeah, so subcostal would be mostly my go-to when I'm doing most people is, I mean, you can get some views midline, but I feel like with the Dopplers, you're doing, the right side of the liver. And so I feel like that, for me personally, that's where I get most of my windows. But again, it depends if they've done a partial or a full transplant. We do those too. We do partials where somebody's donating a portion of their liver. So,
Awesome. Awesome. So what are your rules of as far as angulation and when you're Dopplering those vessels?
yes, well, 60 degrees or less is always, most sonographers know that when they learn Dopplers because it turns red on your machine. So you know that you're like not in the right angle. So just basically angle correcting towards the vessel in the direction of the vessel, especially with arteries. A lot of people I work with aren't super well versed with Dopplers. And I wasn't before I started doing these, so I feel a lot more comfortable with them. But yeah, you want to angle correct towards the direction of the vessel, and you want to be at 60 degrees or less for your angle correction. And that usually works out pretty well for the most part.
So let's talk about the advantages of using ultrasound, right? Versus like MRI or something of that nature. What would you say from your experience, those advantages?
Well, I would say it's not invasive. It's not, introducing radiation, which a CAT scan would do, even though it's lower doses nowadays. And it's really safe for repeating during pre and post transplant evaluations. And frequently somebody will get a transplant, and we may even scan them right after. And then 2 hours later, there's something going on with their vitals, and they will call us back and we will come. We do all of these bedside. And so we could
So,
potentially scan the same liver 3 times in one day. It's not super common, but usually if there's an
yeah.
issue. The other day, I scanned a patient that had a double transplant, a liver and a kidney. And usually they do them at the same time, but for some reason, I don't know why, they did the liver and then they kept his chest open with some of the tape they used. And they brought him back to the ICU. And then later that day, they did the kidney. And so then they ordered both Dopplers again, like it was a double Doppler study, which is like, you
Yeah,
know.
right. Yeah, they're
So,
pretty intense, right?
yeah,
And take a lot of time.
yeah, it
Typically,
was, they do take a lot of time. One of my coworkers who's fairly new to ultrasound jumped in and said, "Oh, I'm gonna do it. I'm gonna, I want the experience." I'm like, "Are you sure?" So she went and did it, and I went up and checked on her, and she's doing fabulous. So yeah, there's those instances too where you do that organ. You may do it several times, or you may do it every day for a week because some of the labs are elevated and they're worried about, or you may see like a fluid collection or something's happening and they want to follow it. So they're pretty on top of it. They really are very
yeah, and I
conscientious.
like the fact that it's portable too, right?
Oh yeah, we
It
go
can
everywhere.
almost be immediate, right? Whereas you're not having to transport the patient anywhere. You can just go right up bedside. It's quick, safe, effective,
Yeah,
uh,
yeah,
cost effective. There's just so many benefits to ultrasound versus other modalities, I think. Like you
yeah,
said, the real time of it as well. They'll stand right next to you while you're looking at it so they can visually see it themselves, right?
yeah.
Uh,
And they
so
can tell us if, let's say, wow, we have this like difficulty with this vessel, so we made it go around this other vessel. They can potentially tell
ah,
us because sometimes they'll do funky things, and we're looking
right.
at the screen going, I don't know what's going on here. And then if the transplant PA is there or the doctor, the surgeon's there, they can say, oh, yeah, so we had to do like an extra this, or the anastomosis is over here instead of over here. So it's helpful to know like what is going.
Beautiful. Yeah, beautiful teamwork. Oh, I
Yeah,
love that.
yeah.
That's almost like cheating.
Well, I don't
I
know.
know my friends in fetal echo, or sometimes us in fetal echo, anytime Vascular is different. It can be a little bit of a hairball to kind of untangle it in your head as far as where things are going and what they're doing, right? And
Totally.
so experience is immeasurable at those points in time, right? And so
Yeah, I agree. The experience, I mean, of course, when we do transplants, a lot of times we don't have a provider there because if it's not a baseline right from the OR,
right,
then
right.
we may be doing a second or third. But it is nice to know like there's some weird vasculature or there's something going on so we can note that on our notes. So when our coworker goes to scan that patient 2 days
Right,
later, we always look at our priors and they
right.
can see, oh, this is this, or this look this way. We can pull, we always look at our images before too. So it's really helpful. And it does foster a lot of like continuity with what we're doing.
Yeah, and expedites the care for the patient in doing
Definitely.
so.
Yeah,
Yeah,
for sure
yeah,
it does.
awesome.
Expedite the care.
Are there any limitations to in liver transplant?
Yeah, I mean, body habitus, like
Sure.
we're finding that they're putting transplants in larger patients. So that can be limiting with what like our views and what we can how, how we can get our pictures. Sometimes it's not a big issue, but sometimes it is. Other limitations can be if the patient's in a lot of pain and just doesn't even, we might have to wait for the nurse to come and give them some medications to help because sometimes we have to push or we have to dig a little bit, I mean, not
Right,
intentionally, but we're just trying to get the pictures we need. I mean, other limitations, bowel gas, people on respirators, so they're breathing, they're respiratory dependently breathing. So you're trying to catch this little tiny artery and they're like,
mhm,
they've got a respirator,
right.
they're not even awake. And
They're not
so
even in control of that. Yeah, yeah,
no.
no
And
one
so
can
in that
control.
instance, we just say, unable to get blah, blah. And then usually they'll have us come back later when the patient's either off the vent or they can manipulate that a little bit more. But yeah, I mean, I always tell my coworkers, we are sonographers, not magicians. If you can't get it, you can't get it. Like you can call for help, we can help each other, teamwork it.
Right,
But sometimes there's a limitation and we just can't do it. And I tell people don't hurt, like be careful with your shoulders and, especially the
right,
new sonographers because they do stuff. I'm like, okay, you need to, you need to be more ergonomically aware because I'm speaking from experience. If you do this long enough and you don't take care of your ergonomics, you're going to have an injury. And
right. And
we
even
all
if you do take care of your ergonomics, right?
yeah,
I
yeah,
think that's an important note to say. Like we could do everything right and we're still going to have issues, right?
I agree.
I mean, proper ergonomics is absolutely necessary. And I find myself readjusting all the time, even after doing it for years.
Yeah, me
I'm
too.
like, oh my gosh, all of a sudden my shoulder's in my ear. And I'm like, why am I doing that? Like,
No, exactly.
you know,
I do try to be, and sometimes I'll stop in the middle of a scan, realizing I'm holding my arm at a weird angle. And I will get some towels and I will roll them up and put them under my arm to support my arm better. And I'm like, wow, why didn't I do that to start with? Yeah.
right,
But
right.
you
Yeah.
learn this along the way, I think,
Well, and it takes extra time. And in a situation that we're in the medical field where everything's in a hurry, 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 do more, do more, do more. It
exactly.
feels like taking the time to roll up a couple towels is just, a waste of time, but it
Not
really
time
isn't.
efficient. Yeah,
Yeah, it
exactly. But
really
it makes a huge difference though
yeah,
for the images because you're probably going to get better images because you're not straining yourself and also for injuries, which, I know I have a coworker that's had shoulder surgery several times, and
mhm,
so we've all kind of been through that. And so just being careful and mindful of it. But as you said, even doing that, we still get issues and stuff happens. A patient can't turn towards you or they can't get into a position, but you need this one picture. And so, you do what you can.
yeah, yeah. And recently, I'm at a location that just got new equipment and in a couple of the rooms and still one room where there isn't good equipment, right? And I can tell the days when I work on the on the older equipment because my body hurts more, because I'm pushing more. And so even good, better, equipment is better for our bodies, right? It's
I so agree with you. And actually, that is definitely a limitation I kind of forgot. Yeah, we are finally getting some newer machines. But we've over the years have been last on the list to get new equipment.
why
And
does
so
that
we've
seem to
been
be the theme?
scanning. Yeah. I mean,
Yeah,
we've been scanning with like 13-year-old machines. One of them just died. It was end of life. So now it's a part machine. And I don't believe we're using it anymore, but the problem is being in a large imaging department. For some reason, we're in a big budget with everyone else. So if MRI's magnet goes out, which costs $1 million, oops, there goes our machine, you know?
right, right,
So it's been a huge frustration over the years, but we have a manager now that's really proactive, and so we just got two new machines within the last 6 months, so that's been great. So hopefully we'll stay on that, and we'll just continue to stay on top of it because again, with a body habitus issue, your images are not great. On a 13-year-old
right,
machine, there is a huge difference,
right,
huge. The
right.
new machines are,
And you struggle
yeah.
so much more.
I'm
Yeah,
like, why can't I
absolutely.
see? And well, it's because the machine's old. It's tired. It wants to go lay down somewhere.
Right? Yeah. And
Yeah. So that is a
also
huge,
knowing that in medicine, we like to confirm diagnoses in several different modalities, right? So just because ultrasound says this, we might also be able to see it a different aspect of that disease process through the CT or the MRI, right? Can
yes,
help. It's almost like putting together a puzzle, right? Like, what are the
exactly.
different angles that we can look at this that's going on with you, this process,
Yeah.
and
It's
we
like
get
a
a little bit
puzzle.
different information from each modality, right?
Yeah,
So,
definitely. And that's when people ask me, like, why did I just have a CAT scan and now I'm doing this? Well, because all these modalities complement each other. We all look at things differently. I can see soft tissue, the CT can see something else, the MR can see something else. So if they're looking for this one thing, but they're not sure, and you just had a CAT scan and it was negative, well, maybe it's your gallbladder. So, I try to explain that to people in a way that it's hard because everything's so expensive and people are really, mindful of like, wow, I just came to the ER and probably this is going to cost me $10,000. But
right.
that's probably another story.
Yeah, right, right.
Yeah.
So just in closing, ultrasound is a great tool for so many ways, right? It's a good way to start the process of looking to see what things are going on and almost a screening,
Yeah.
and then we can kind of zone in and kind of get more diagnostic over specific things when we find different disease processes going on.
Yes.
Do you have any numbers on how, well, I guess it's really dependent on the location, maybe even how successful transplants are?
Oh, I actually don't have numbers. I did not pull numbers from the hospital I work at. I know that we have a fairly high success rate at the hospital I work at, but they do a lot of transplants. But I don't have the actual numbers in front of me. But
Yeah,
I
I
think,
think anytime that there's a system, hospital system that has that service, I think there's
mhm,
a high number of success, right, with transplants because they do so
yeah,
many. And so they have quite a bit of experience in knowing a lot of variation things and what to look for and different things like that. And usually the surgeons and doctors are super experienced, right? And have
yeah, you're very
years of
experienced.
training and different things like
Sometimes
that.
sometimes they'll tag team, like I'll see two surgeons' names on there, and they'll tag team a case, whether I don't know if it's because it's maybe a little more complicated because they have to do some extra stuff,
Mhm.
or just they tag team sometimes. So I've noticed that sometimes they will, assist each other. And yeah, they're really knowledgeable. And while we don't get to talk to them all the time, we can reach out to them if we have questions. We've asked them to please, if possible, which isn't always happening, can you let us know if there's something unusual about what you did
Mm-hmm.
hooking up the vasculature, or something we need to know about that might impact what we see or how we see it or how it's evaluated.
Now, do
So,
your doctors do the ultrasound themselves in the OR, or do you ever go to the OR with them?
oh yeah, no, luckily, I was called into the OR once, probably, I don't know how long ago, it was probably 5 or 6 years ago, and which was unusual because we never go to the OR. It's always the ICU or the PACU. If we're doing a kidney transplant, we scan them in the PACU. No, one of the doctors couldn't get a vessel, and so I walked into the OR thinking I was just going to run the machine for him, and he was all like, "Well, the liver's right there," and the patient's chest was like wide open, and I was like. Then the doctor left and they wanted me to scan. I said, "Yeah, I'm not comfortable doing that. I'm happy to run the machine for the doctor and like help him with stuff, but I'm not comfortable putting my hand in somebody's open chest because it's so different than, scanning a patient with skin on, right?"
Yeah. Right.
So I said, no, thank you, but I'm happy to help. So, but yeah, usually no, we don't get called into the OR for something like that. I think that was a one-off, and
Yeah.
that hasn't happened. So hopefully it
I
won't.
love going to the OR. And so I just wonder how many other people like going to the OR, only because
I
I
don't love it.
love, you don't like it?
And it's not that I don't love it once I'm in there because it's so cool and interesting. I just hate like putting everything on, and there's so many rules,
Oh,
and
yeah. Right, right. Yeah.
but it's
I
cool to
mess up
be
the
in there.
rules all the time. Yeah. Yeah. I have to be reminded because I didn't always go very often. Then I took a job where I went more often and I'm like, oh, I screwed that process up so many times. It wasn't even funny. It was really embarrassing more than anything.
Yeah,
Um,
they know.
But
They
I
help.
love the fact that in the OR, everybody lays their ego at the door, right? And when you walk in, everybody's such a team, and especially when
Yeah,
there's two surgeons working, to like hear them talking back and forth in their
yeah,
work approach to things. It's just
yeah.
a cool feeling to me. I just love the fact that like 25 people can be all focused on one person for their success,
Right.
right? Like we're
Yeah.
watching for, I mean, when you do the timeout, everybody's watching for fire hazards and
Yep.
the temperature of the room and like so
Yeah.
many
Yeah.
things that people just, if they knew what everybody did to try to keep them safe.
It'd be kind of blown away by the team
Yeah,
effort, probably.
blown
And
away, but yeah, also a little bit more relaxed. And so when I hear patients or friends who are like, "Oh, I've got to go in for surgery," I'm like, "You're gonna do great." Like there's like all these people that surround you to make sure that you're safe and that you're comfortable and that
definitely
things are gonna go swiftly and accurately and things are documented appropriately and I mean things,
100%. Yeah, I agree with you. And I know we didn't touch on this, but like we do a lot of liver biopsies for patients in liver failure.
sure.
And so the patients get like kind of a sedation that is their sort of what's it called? Blanking on the name of it, but they're
Versed? Do they
yeah,
use
something
Versed?
like Versed. It's just they're not under deep sedation or anything,
Right.
and there's not an anesthesiologist in there. It's just a nurse administering some Versed, and we do the same thing. Like you said, we do a timeout. We make sure we ask the patient, "What are you having done today?" Before we sedate them. They sign a consent. They sign a sedation form. All of the radiologists, the interventional radiologists are really awesome. And they are all so kind, and they will tell the patient what they're doing, how they're doing it. Do you have questions? And, patients afterwards, they say, wow, that was really easy. Or I can't believe that went so fast, because
Yeah.
it's usually a one and done on the liver biopsy, like one sample, put it in the thing and I go tube it, and
Yeah.
we're done in
Yeah.
5 minutes. It's the setting up and the
Right.
making
And the
sure
taking down.
everything's
Right. Yep.
okay,
Yep.
and
Yeah.
nurse coming in with medicine and monitoring the patient and all of that stuff takes way longer than the actual biopsy. So yeah,
Mhm.
I think patients for the most part nowadays are the safest they've ever been, really, in my
Yeah,
opinion.
absolutely. Right.
Yeah, so it's a good point that you brought up.
Yeah. So, transplants do save lives. They extend lives
Yeah, they
through a
do.
good, thorough workup, closely monitored, right?
Very
Um,
close monitored, yes.
but also after you have transplants, I believe, you're on a regimen of a whole bunch of medicine, right? To not reject that
Right.
transplant. Is that correct?
Yeah, you're on a lifetime of anti-rejection medicine, which you have to take. Otherwise, because your body knows that that's not your organ, so it tries to reject it. So you're on anti-rejection medication. You're on a lot of stuff, which I don't know all of it. I just do know that the anti-rejection medicine is crucial. And we've had patients come in because they've stopped taking it for whatever reason, or it needs to be adjusted. Sometimes patients like have some issues and it just needs an adjustment. And we'll do a biopsy just to see like, hey, what's going on with this liver? Maybe it needs more of something or less of something. So
Right.
the
Right.
medicine is lifelong. I mean, you have to take any time you put an organ that's not yours in your body, you have to take anti-rejection medicine or your body isn't going to attack it and think it's a foreign body, which it
Yeah,
is.
isn't that amazing? Isn't
Yeah.
that amazing? Like
Pretty
our
cool.
own bodies know that's not our own liver, right? Like that's
Yeah.
amazing to me.
It is
Like
pretty
not
body.
all livers are equal, right? Like you know,
That's true. Yeah,
let's just go with that,
it's
right?
true. I mean, it's kind of like if you get an infection, and your body attacks because it knows that infection is
Right,
good. So your body like innately knows what to do, and so you can't blame your body for trying to reject something that's not really your
not
body's thing,
right.
even though now it is your thing.
Yeah, right.
So
It's
yeah, it's kind of
amazing.
interesting when you
Our
think about
body
it.
is so amazing, isn't it?
It
And
is.
and I tell people all the time, our bodies know what to do. It's
Yeah.
not rocket science, but
Mm-mm.
yet we sometimes we need rocket science, and we
Uh-huh.
as humans have come leaps and bounds to rocket science, right? You
Yeah.
know, I I think it's just amazing where we've come from to where we are now, and the improvements, and
Yeah.
and to think that it'll get better, like we're
Yeah. I
always
mean,
getting better, right?
even with our ultrasound equipment, as you've been scanning a long time too, and just knowing
Right.
like where I started from and thinking, I don't know, I think that's a kidney to today,
Right.
where where you can see like every single vessel in the kidney
Right.
when you put your power Doppler or whatever,
Right.
your high flow stuff on, and you're just like, wow, that's so cool. Like I can see all the tiny, tiny little vessels in there. So
Right.
it's
Right.
really like amazing where we were 30 years ago or however long.
Well, a big, huge shout out to the engineers, right? Who listen to
Yeah.
us and who go back to the building blocks and building boards of
Yeah.
technology, right? Like
Yes. And listening
we
to the
can't say
finicky, yeah, and listening to the finicky sonographers who say, no, that button cannot be there. You need to move it. It needs to be here.
enough.
It
Right.
doesn't make sense because, they're thinking with their engineer minds, but and I think GE, we have all GEs. I think they do work with sonographers on the knobology stuff because
Mhm.
that is super important to know where your
It
buttons are and that they're in an ergonomic and they're in a smart location. Otherwise, I don't know, it's just really difficult.
is. Right.
So
I was working on a new machine the other day, and I was looking for a certain button, and I could, out of the corner of my eye, see the patient kind of look at me and not the screen. Like, what is she doing? And I'm like, I'm sorry, this is a new machine. All machines have the same buttons. They just sometimes put them in a different place and sometimes call them a different thing. Like it's
it's true. I've had to say that too when I've just stopped and just stared at my touch screen or something. I'm like, I know it's here somewhere. And so, yeah, I usually say the same thing. This is a new machine. I'm just trying to figure out where this particular button is. So
Yeah.
just give me a sec here.
Yeah, but hats off to technology and the engineers that have listened to us. And we have so many demands and we have so many requests. Excuse
We
me.
do. Yeah, we do have a lot of,
And they've done a beautiful job to listen to us and accommodate us. I mean, just in one department, when they bring
Mhm.
a machine in and they want to set it up, I'm like, oh God, help us. Like we all have a different opinion of how we want our settings, right? Like I like it
Oh,
darker, I like it lighter, I like it this way, I like, and
we,
so
yeah, so we've gone to Scan Assist for 90% of our exams, which I resisted with every fiber of my being when it first came out. And now I love it because I just know what comes next. And the settings are pretty much, I mean, you can tweak them a little bit depending on what you're looking at, but it's just all there. I won't miss any anatomy because it just pops up and it's like bile duct. Oh yeah, now it's time to measure. So, I mean, I really appreciate the Scan Assist, and for anybody who's resisting Scan Assist, just give it some time. You will
yeah,
start to
yeah,
not hate it after a while. It takes time because you're used to doing things a certain way in your head, but it really does make things faster and more efficient. So I
yeah,
do,
and I would second that opinion. Because in the world of OB, I went to a place where they had it and I could jump around in the a scan assist, right?
right, you
So
can.
it's not locking me into I have to get this image right now. It never
Exactly.
locked me into that. I could jump around through that. The benefit for me or was that after I did 100 pictures, I could see, oh yeah, I got everything that was on my checkoff list that I needed, right?
Exactly.
So I'm
Yeah.
not walking in and out of that room constantly checking
Yeah.
and rechecking or going to the
Yeah.
computer and then going back to my ultrasound. So
Exactly. Yeah, it checks
it
it off for you. So you can see, oh yeah, I did all those pictures, but these are not checked off. So I need to make sure I get those done. And then looking in your end chart, of course, I always look through that and make sure like I've got all my measurements that I need. And, that's my final thing that I always look at before I end my exam to make sure I got it all. Sometimes a measurement for
right,
some reason won't take, it won't
right,
show up in the measurement chart. And then the radiologist doesn't like that. So, we try to make them happy too, because
right, right.
so yeah, it's a
So
process.
yeah, I definitely resisted it at first, but then after I used it, I just loved the tool. And so
Yeah, same.
yeah, I think it's every time I do a podcast and talk to someone new and different about a different technique or a different specialty, I just have this growth of appreciation for what we do, right? And the team of people that it takes in order to do it, right? Like it takes the engineers listening to us bitch and moan about whatever we're bitching and moaning about,
Right. Right,
to
right.
bring about the change. And I know a certain company came out with a new machine and their first rollout was a little rough, quite honestly, on a few things.
Yeah,
And so their new rollout was maybe a year and a half ago, maybe 2 years ago. And now looking at their new rollout, they've made some huge changes, right? And so
they
just
listen.
in the short amount of time
Yeah.
of a new machine, the new brand new off the um production line is kind of a rough go, right? Like your first
Yeah.
rollout is like, oh, here we go, let's try this, right?
Right,
And
right.
then comes all the tweaking and turning and let's
Yeah.
refine this. And they've
Yeah.
done an excellent job of refining and
That's a
making
good
it
company
even
then.
better, you know.
Yeah, they
So
listen.
they listen, they do make changes. So thanks to everyone involved in making our
Yeah.
lives better and different and
Easier. Yeah.
easier. Yeah. And I mean, that's part of our ergonomics, right? Like I'm not really having to push and for a long period, different things
Yeah.
like that. So
Yeah.
And it's better for the patient. The patient isn't sore afterwards, from us pushing. And
Yeah.
so
I think it's just overall better for everyone. We don't get injured. The patients don't complain. We're pushing too hard.
you get
And
better information for the doctor.
we get prettier pictures with more and better information. And it's just a win-win, really. So
It's a
yeah.
wonderful modality to be a part of. So if
Yeah.
anyone's thinking about it or on the line of not knowing what to do with it, please talk to somebody.
Yeah.
We're
Yeah. I mean,
all
also,
love to share our highs and lows of everything, right?
definitely. And if you are interested in getting into the world of sonography and ultrasound, my recommendation is try to shadow a few techs or a technologist, if you can, and maybe reach out to your local hospital. We've had some students from the high school come and they'll just follow us and they can see what we're doing, how we're doing it, listen to our banter in the tech room and decide, if they want to be a part of something like that. Um, and it's a really great way to just get firsthand information on what you potentially might be doing as a career, and instead of jumping into something where you really don't have a clue, which I kind of did that because I didn't have that opportunity. I mean, I don't regret it, but it would have been cool or nice to be able to like go follow a sonographer for a half a day and just ask
Right,
questions and watch what they do and how they
right.
interact with the patients and the doctors and the mid-levels. And so I recommend that if anybody's interested in doing um, ultrasound. Yeah.
Yeah, I second that motion as well. Well, thanks so much for your time and sharing your expertise in regard to and our role as ultrasound techs with it certainly is life-saving and life-changing for patients. And like
Yes.
Juliet mentioned before, just the experience that people have working alongside someone with experience in these transplants is monumental. So if you ever get a chance to work alongside someone who has lots of years of experience with these, you'll learn much faster.
Yes, I
I,
agree.
I highly recommend that. And thank you. Thank you for your time.
Thank you
One
for having
last
me.
question. I've been forgetting to ask all my guests, but my
Okay.
intention is to ask. This podcast is it's all about your frequency. So, what do you do in your life to increase your frequency?
Ooh, that's a really good question. I do many things. As a health coach, I have habits that I partake in to help increase my frequency. I am a huge proponent of body movement. I am a CrossFitter, and so I love to work out. I love to spend time outside in nature. I love reading. Those are my kind of reset, increase my frequency go-tos.
Go
Dark
to
chocolate's in there too.
dark
Got,
chocolate. Absolutely.
got the dark.
Awesome. Well, thank
Yeah.
you so much. We
Okay.
appreciate it.
Yeah, thank
We'll
you.
talk to you soon.
Okay, bye.
Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.